Okay, so here's our third clinical correlation, which is atrial pathology. So we'll begin with a case. This is case number 3. Ms. Frankel is a 23-year-old female with a past medical history of palpitations. She had intermittent palpitations since she was a teenager, but they have worsened in the last 6 months. There are no known triggers, but she says that breath holding sometimes helps. Today you see Ms. Frankel in the ED, where she is complaining of palpitations that started suddenly this morning. She feels a little lightheaded and feels her heart racing. No chest pains and no syncope on the interview. Her vital signs include a temperature of 97 Fahrenheit, a pulse of 150, respiratory rate 22, and blood pressure 110/57. Physical exam shows a fast, regular heartbeat, normal S1, S2, no rubs, clicks, or murmurs. Lungs are clear, extremities are warm and perfused, and the ECG shows the following. So the question is, which of the following diagnoses is most likely? A. Sinus tachycardia. B. Idioventricular rhythm. C. Accelerated junctional rhythm. D. Ventricular tachycardia. Or E. Supraventricular tachycardia. And before I show the answer, I will go back to the ECG. Here are the question choices, and the answer is supraventricular tachycardia. So if we go back and look at the ECG, we see a rapid, narrow QRS tachycardia. And we see that the P wave is really difficult to find here. In fact, the P wave may actually be buried within the QRS or within the T wave. So because the P wave is buried and because the patient has tachycardia, it is really difficult for us to find it. This is a classic ECG for supraventricular tachycardia. And here is our next question, which is, what is the next best step in the patient's management? Is it A, oral beta blockers, B, vagal maneuvers or adenosine, C, synchronized cardioversion, D, unsynchronized cardioversion, or E, intravenous diltiazem, which is a calcium channel blocker? So the answer is B, vagal maneuvers or adenosine. And really this is both diagnostic and therapeutic. So when you perform vagal maneuvers, this essentially temporarily shuts down conduction within the AV node. And adenosine is a chemical way to do the same. Essentially, you're shutting down temporarily AV nodal conduction. And what this does is, because most SVTs like AV-NRT or AVRT rely on the AV node, is that this can actually help you diagnose SVT. And it also helps treat the patient, right? So if you're able to break the arrhythmia and then they reestablish sinus rhythm, then it's both a diagnostic and a therapeutic modality. And in the guidelines, the SVT guidelines that came out a few years ago, when a patient presents with regular supraventricular tachycardia, your first move is to perform vagal maneuvers, and if this doesn't work, then give intravenous adenosine, which has a very short half-life and which suppresses the AV node. And only if this is ineffective or not feasible, that's when, in a hemodynamically stable patient, then we can consider some of these other intravenous drugs or a cardioversion, which were the other answer choices. Now, obviously, if a patient is hemodynamically unstable, and that just simply means that their organs aren't perfusing well, maybe they have renal failure, or they have poor distal pulses, or they're not mentating well, something to demonstrate that they're not perfusing their body well, that's hemodynamically unstable. And, coupled with a low blood pressure, you may give a synchronized cardioversion. So vagal maneuvers are performed in this patient and yields the following ECG response. So take a look at that for about 10 seconds. So the follow-up question is, what is the most likely diagnosis of her palpitations? Is it A, atrioventricular reciprocating tachycardia, B, atrioventricular nodal reentrant tachycardia, C, junctional tachycardia, D, atrial tachycardia, or E, atrial flutter? So the answer is AVNRT, or atrioventricular nodal reentrant tachycardia. And of the SVTs, this is the most common SVT, and AV node reentry usually occurs in and around the AV node when the AV node has a fast and a slow pathway. And essentially, in this tiny geographical area, you can have a micro reentrant circuit that sends signal to the ventricle and then up into the atrium. And so, because this occurs in the center of the heart and activates the ventricles and atria simultaneously, usually the QRS and the P waves are on top of each other, and the P wave is difficult to see. AVNRT is the most common SVT. A less common SVT in this situation that would also rely on the AV node would be the atrioventricular reciprocating tachycardia, or AVRT. And because the patient had a response to AV nodal suppression, it's less likely to be junctional tachycardia, atrial tachycardia, or atrial flutter, because these maneuvers actually caused a rhythm change back to sinus rhythm, which you saw in the second ECG. Moving on to case 4. Mr. Davis is a 67-year-old male with a history of hypertension, diabetes, congestive heart failure, and stroke, or TIA, who was in his usual state of health until about 2 weeks ago when he developed symptoms of feeling sluggish, short of breath, and symptoms of palpitations. He denies chest pain and denies any other symptoms, and today he comes to your clinic for advice. On physical exam, the patient's vital signs are temperature of 98 Fahrenheit, respiratory 20, pulse 79, blood pressure 136/88. The thyroid is normal to palpation. The lungs have mild crackles at the bases. The heart has a normal S1, S2, but the rhythm is irregularly irregular. There are no rubs, clicks, or murmurs. The abdomen is soft and non-tender, and the extremities have 2+ pulses and no edema. And here's the ECG. So the question is, what does this ECG show? Is it A, atrial fibrillation, B, atrial flutter, C, atrial tachycardia, D, sinus rhythm, or E, AV nodal reentrant tachycardia? And here's the ECG again. So the answer is atrial fibrillation. And we can see, if we flip back here, we see that there's really no P wave before every QRS. Instead, we see erratic fibrillatory activity in the atria. And then the QRSs are narrow, but they're irregularly irregular, meaning that if you were to measure the distance between one R wave to the next R wave, you couldn't use that information to predict the next R to R interval, or even the next R to R interval. So because it's irregular and because you can't predict it, there's an irregularly irregular QRS. And this is a hallmark of atrial fibrillation. So the next step in the patient's management should include A, an antiarrhythmic drug, B, a cardioversion, C, echocardiogram, D, oral anticoagulant, or E, home telemetry monitoring. So the answer is oral anticoagulant. So for patients with atrial fibrillation, including those with paroxysmal atrial fibrillation, stroke risk should be assessed using a risk factor-based approach. And the current guidelines recommend using the CHADS-VASc score to predict a patient's risk of stroke when they have atrial fibrillation. For patients with atrial fibrillation, stroke prevention with oral anticoagulants should be offered if the score is greater than or equal to 1 in males or greater than or equal to 2 in females. And here's the CHADS-VASc score broken down. And on the left, you can see that C stands for congestive heart failure, H stands for hypertension, A stands for age over 75 years old, D stands for diabetes, S stands for stroke, and if the patient has had a stroke or a TIA in the past, then they actually get 2 points for that instead of the usual 1 point. V stands for vascular disease of major blood vessels. The second A stands for age between 65 and 74, and SC stands for sex category, meaning that in females, if they have other risk factors, then they get a score for female sex. And on the right, you can see an illustration just showing that as the CHADS-VASc score increases, then that's associated with a linear increase in stroke risk if you have atrial fibrillation. Okay, so on to case 5. Mrs. Chen is a 60-year-old female with heart failure with preserved ejection fraction and hypertension. She is admitted to the NICU for a stroke involving the left MCA arterial distribution with corresponding contralateral weakness and visual field defects. She received early intravenous TPA with partial improvement of initial motor and sensory deficits. So while Ms. Chen is in the NICU, a routine ECG shows the following. So which of the following is the next best step in her cardiovascular management? Is it A, rate control strategy with an oral beta blocker, B, rate control strategy with an oral calcium channel blocker, C, rhythm control strategy with direct current cardioversion, D, rhythm control strategy with amiodarone, which is a class 3 antiarrhythmic drug, or E, anticoagulation with oral Coumadin? And again, I'll show you the ECG. Okay, so the answer for this question is rate control strategy with an oral beta blocker. So a calcium channel blocker is not really the first line choice because it's a negative inotrope and is relatively contraindicated in heart failure. Rhythm control strategy is really not desirable and is unproven because the patient's not yet anticoagulated. So we would need to ensure that the patient can be anticoagulated first. And really, we would need to make sure that the patient has no blood clots in the heart from the atrial flutter, which we found on the ECG. So the answer to the ECG is atrial flutter, and then our response then is to give a rate control strategy like an oral beta blocker and not yet a rhythm control strategy because the patient may or may not have an intracardiac clot and we don't want to convert the rhythm until we know that we aren't going to cause further stroke. Now, some of you may have chosen E, which is anticoagulation. It might be helpful for future stroke prevention, but we would need to talk with the neurology service first to determine the patient's secondary conversion risk to hemorrhagic stroke, right? So we wouldn't want to give an anticoagulant too early because we might take a ischemic stroke and actually convert it to a hemorrhagic stroke. So we would need to talk with the neurology service and potentially the neurosurgery service to see what their thoughts are about that prior to starting anticoagulation. But in the meantime, for this atrial flutter, what we can do is at least control the heart rate with an oral beta blocker. So the SVT guidelines state that in a patient with atrial flutter, we need a treatment strategy that can either be either rate control or rhythm control. We chose rate control for the aforementioned reasons, and a beta blocker would be reasonable to help with rate control. And we probably don't want to use a calcium channel blocker like diltiazem or verapamil, simply because these are relatively contraindicated in heart failure. Rhythm control strategy could be used, but we would need to make sure that the patient doesn't have an intracardiac thrombus prior to considering this strategy, and also the patient would need to be anticoagulated at that time.